Aortic dissection is one of the most time-critical cardiovascular emergencies in the MRCP exam and in real clinical practice. If you recognize the pattern early, you save a life. If you miss it, mortality rises hour by hour. An aortic dissection occurs when a tear develops in the inner lining of the aorta. Blood then enters the aortic wall and splits it into two channels, a true lumen and a false lumen. This creates a rapidly progressive and potentially fatal condition. The most important classification for the exam is the Stanford classification. Type A involves the ascending aorta, with or without extension further down. Type B involves only the descending aorta, beyond the left subclavian artery. This distinction is critical because it determines management. Type A equals surgery. Type B, if uncomplicated, equals medical treatment. In the DeBakey system, Type 1 involves both ascending and descending aorta. Type 2 is confined to the ascending aorta. Type 3 is confined to the descending aorta. So remember the simple exam rule. Any dissection that touches the ascending aorta is type A and needs emergency surgery. The most important risk factor is hypertension. Other major associations include Marfan syndrome and Ehlers-Danlos syndrome, pre-existing aortic aneurysm, bicuspid aortic valve, cocaine use, major trauma and pregnancy, particularly in the third trimester. The classic presentation is sudden, severe chest pain. Patients often describe it as tearing or ripping. The pain typically radiates to the back. As the dissection extends, the clinical picture changes. You may find unequal pulses between the arms, blood pressure differences between limbs, hypotension if rupture or tamponade develops. If the ascending aorta is involved, a new early diastolic murmur may appear due to acute aortic regurgitation. Neurological symptoms such as syncope or stroke occur when the carotid arteries are affected. If branch vessels are compromised, you can see myocardial infarction, renal failure, bowel ischemia, or limb ischemia. The complications explain the high mortality. Rupture into the pericardium causes cardiac tamponade. Rupture into the pleural cavity causes hemothorax. Acute aortic regurgitation leads to heart failure. Cerebral vessel involvement causes stroke. Spinal artery involvement may cause paraplegia. For diagnosis, CT aortic angiography is the gold standard in stable patients. In unstable patients, transoesophageal echocardiography is preferred because it can be performed at the bedside. MRI is highly accurate, but not practical in an emergency. A chest X-ray may show a widened mediastinum, but a normal X-ray does not exclude dissection. Management always begins with rapid blood pressure and heart rate control. Intravenous beta blockers are first line because they reduce shear stress on the aortic wall. If further blood pressure reduction is needed, a vasodilator such as nitroprusside can be added, but only after beta blockade is established. Now the key MRCP decision point. Type A dissection is a surgical emergency. The ascending aorta must be repaired or replaced, and complications such as tamponade or severe aortic regurgitation must be treated immediately. Without surgery, mortality is extremely high. Type B dissection, if uncomplicated, is treated medically with aggressive blood pressure control. Endovascular repair is required if there is rupture, persistent pain, uncontrolled hypertension, organ ischemia, or expansion. Prognosis depends on the type. Type A has a very high mortality without urgent surgery. Type B has a much better outcome if uncomplicated and well controlled. Long-term survival in both groups depends on strict blood pressure control and regular imaging follow-up to monitor the aortic diameter. So for the exam, anchor the diagnosis with this pattern: sudden tearing chest pain, radiation to the back, pulse or blood pressure asymmetry, and a widened mediastinum on chest X-ray. Then immediately classify. Ascending aorta involved. This is type A. Call the surgeons. Descending only. This is type B. Control the blood pressure. That single decision saves lives and scores marks in the MRCP. Final memory line. Type A dissection, surgery. Type B dissection, medical treatment unless complicated,